from our side in cardiology, from the side of obstetrician. And at the last trimester, we will do the consultation also for the cardiac anesthesiologist and also the perinatologist or the neonatologist. We will review the clinical status, echocardiography, and also BNP at the third trimester. And if necessary, we will do the 6-minute walking distance. If the patient is having clinical deterioration or signs of right heart failure, then we will admit the patient or we will advise for medical termination according to the clinical condition. Now, what about the mode of delivery? Patient actually can still do the vaginal delivery whenever the patient in a low risk profile. But in those with having a high risk profile, so elective cesarean section for severe PH and also Eisenmenger syndrome will be advised with a careful choice of anesthesia agent. And stage 2 labor with pushing is actually contraindicated. So this is some algorithm what we have to do for PH patient, pregnant PH patient. So at the beginning we see the clinical condition and advice or offer termination. Otherwise, we will do the expert multidisciplinary team, and then, of course, we will provide the pulmonary vasodilator therapy and do the close monitoring of the patient if there's any clinical condition appear. Do the NT-proBNP at the first trimester, at the third trimester, that's what we usually do, and delivery we usually perform in around 34 weeks. So this will be in the form of the planned delivery instead of spontaneous delivery. And a careful watch of postpartum monitoring. Yeah, I think this will be just similar. And this is another evidence that when the patient is having pulmonary artery PH targeted therapy at the very early stage, before pregnancy or even in the early pregnancy, the patient will have maternal and perinatal outcome as compared to those who only receive sildenafil in the first or second weeks before delivery. So in that case, actually, we still can manage pregnant patient with PAH with a very careful observation and initiating the PH targeted therapy at the early stage. Now, what kind of drugs we can provide to that patient? I think Emoto Sensei already explained the fourth pathway. And among those fourth pathway, I think sotatercept has not been admitted to the guideline. But among those three pathways, on the endothelin receptor antagonist is contraindicated for the pregnancy because the effect of teratogenic. So in pregnant female with pulmonary hypertension, we will provide PDE5 inhibitor and also prostacyclin or prostanoid agent whenever necessary as a combination therapy. Yeah, so back to our patient. So the patient is declined medical termination. Her initial NT-proBNP level is 750, but the clinical follow-up at 31st week, the NT-proBNP level can be decreased to 300. So the effect of sildenafil and the better functional class actually shown by the decrease in NT-proBNP level. And since the patient is having anhydramnion, so the patient is scheduled for emergency cesarean session with non-intubated general anesthesia because we think intubation will having a more detrimental effect to the patient. And 24 hours after partus, we monitor the patient in the ICU for close monitoring, and as expected, in 24 to 72 hours after delivery, a patient with intracardiac shunt and severe pulmonary hypertension will usually have decrease in oxygen saturation. And this also happened in this patient. You see the oxygen saturation decreased to 88%. So we adjust the sildenafil and also optimize the iloprost. And after careful monitoring, the patient can be discharged in a good condition. Still not a very optimal oxygen saturation, but she can have a good 6-minute walking distance. So the take-home message in this case is that pregnant women with PH need special consideration for that pregnancy and delivery. And management and therapy should be tailored individually and in multidisciplinary approach. That is the most important thing that we have to do. Emphasis on treatment should be on preserving euvolemia and preventing systemic hypotension, hypoxemia, and acidosis. And mode delivery of patient with pregnancy could be cesarean procedure or vaginal birth according to the clinical condition and the risk stratification of the patients. Again, on behalf of the cohort PH team, I would like to thank all of the audience for this wonderful afternoon. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Diah Wulan, for the clear but rather, but very nice. Thank you. Now we will begin for the session for question and answer. Anybody wants to ask? Yeah, please. You can come to the microphone and please introduce yourself.
Check. Yeah. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, doctors and professor. Thank you very much for the lecture. It was very concise and very clear. And I would like to ask a question regarding the PAH in pregnancy. Is it possible for the PAH to at least revert to previous condition after the termination of the pregnancy? Or is it still as devastating as when the patient was still having the pregnancy? As in, would the disease progress after the pregnancy? Yes, that is the question.
So you're asking about the regression of the pulmonary hypertension after the pregnancy?
Yes. Thank you very much.
Yeah,
yes.
Thank you. If you're asking about the case, the patient is already having pulmonary hypertension prior to the pregnancy. That will not regress after delivery. So for sure, because the evidence is when we evaluate this patient, all the parameters are quite similar, and unless there is a cause during the pregnancy that may worsen the pulmonary hypertension, like pulmonary thromboembolism in pulmonary artery, then we can regress. But otherwise, if it's the remodeling or if it's because the disease in the pulmonary vascular, the remodeling and the proliferation in the pulmonary vascular, in that case, I don't think it will regress after delivery. So, in fact, in some patients who's having pregnancy, they show the symptoms during the pregnancy. And before the pregnancy, they didn't show any symptoms. So again, pregnancy can be good, not good, in terms of showing the symptoms of pulmonary hypertension. But actually, since some people think that dyspnea or shortness of breath, we underestimate shortness of breath. So once they go to pregnancy, then it will be very noticeable that all the signs and symptoms are shown up. Thanks.
Thank you very much.
Thank you for the question and for the simple answer. Yeah, please. Please introduce yourself and the institution you are now work.
Yeah. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, professors and doctors. Thank you for the opportunity. I have questions in real case of my patient. I am Mufti from Bandung, doctors, professors. In the case, the patient is the patient with the cardiac cirrhosis or the right-sided heart failure and reduced ejection fraction of about 19 until 20%. And then the patient is previously being admitted to the ICU, and then she can go back to home. And then about 1 until 2 weeks from that time, she came again to the hospitals, and then with the chief of complaint, shortness of breath. And then we do the physical examinations, but unfortunately the blood pressure is low, about 80 per 60 millimeter mercury. And then the patient has before the pemulangan, go back to home, is undergone the drugs that is sildenafil, doctors. Then from 2 weeks from that, the patient come again to the ER with that complaints. And unfortunately, patient goes to the ICU again and being admission about 8 days. And unfortunately, patients died in the ICU. My question is, for the case of the patients, is there any correlation about the administration of early sildenafil to the incidence of systemic vasodilators that maybe worsen the symptoms of the failure? Thank you.
Thank you for the question. Dr. El, maybe, or Prof. Emoto?
Okay, thank you very much for your question. Yeah, I think it's very, very tough case. And usually when we have a patient who have a very severe right heart failure due to the pulmonary arterial hypertension, we need the extensive therapy, including catecholamine, especially by supporting the cardiac output. And at the same time, we use epoprostenol, prostacyclin infusion. So both the pulmonary arterial hypertension therapy and cardiac support therapy. In some cases, we use ECMO, so mechanical cardiac pulmonary support, to overcome such period. If epoprostenol is effective, we may rescue those very tough situations. But yeah, honestly speaking, it's very, very, very tough. So in my opinion, before getting those stage, it would be better to actively treat those patients. I'm not sure if this is right answer or not. Thank you.
Yeah, maybe a little additional comment. Yeah, maybe the first thing we need to make sure what the underlying of this case. I mean, you said that the patient is already in the low ejection fraction. So I think, I don't know, this is the left heart disease or what the underlying of this patient. I mean, when this patient is pulmonary hypertension due to the left heart disease, the main problem is on that condition. Is there any place for the sildenafil in the left heart disease? So when we already make sure what the underlying the patient, we can give the precise treatment for the patient. And maybe, Dr. Wulan, do you have any comment maybe for the sildenafil in the left heart disease?
No, I don't really catch your question. Is it pulmonary arterial hypertension or is it due to left heart disease? Due to valve disease or LV dysfunction, or is it pulmonary hypertension? What is the underlying condition of the patient? You can use the microphone.
Okay, I'm sorry, doctors. The patient is the hepatorenal congestions and then is going to the pulmonary arterial hypertension to do the echocardiography with the enlargement of the right-sided
Right-sided.
heart.
So
Yes.
without any involvement of the left side.
But
Of the
the
heart?
low ejection fraction, doctors, and
Oh, with low
with
ejection
low
fraction.
ejection fractions at that moment.
Mitral stenosis with low ejection
Is
fraction,
it mitral
right?
stenosis?
Am I right with valve also?
Okay. Maybe there's no valve problems
No valve
based on
problems,
the
okay.
No
echocardiogram.
valve
So
problem.
in that case, I think we made a mistake in answering your question. So in the case of low or low LV function, the pulmonary hypertension in that patient should be carefully evaluated for the phenotype. I mean, LV dysfunction can be advanced into right ventricular dysfunction, so biventricular dysfunction, and it's very difficult to manage. And in that case, sildenafil, I don't think it is the right indication for low LV function. So we should treat the LV instead of giving sildenafil.
So maybe the better solution maybe treat the low LV function rather than sildenafil, right? Okay. Thank you very much for the contribution from Dr. Real, Prof. Emoto, and Dr. Wulan. Maybe I would like to highlight the take-home message from the three speakers. First, the pulmonary arterial hypertension is a multifactorial disease such as smooth muscle proliferation, endothelial dysfunction, inflammation, and resistance to apoptosis, and epigenetic factors, metabolic disorder, inflammation, hypoxia, oxidative stress, and vascular injury play important role in PAH. And the therapeutic approach targeting the activin A signaling pathway, including the use of sotatercept, is anticipated to become an effective new treatment for pulmonary arterial hypertension. In addition to existing three classes of medication, and pregnant women with PH need special consideration for their pregnancy and delivery, and management and therapy should be in multidisciplinary approach, and mode of delivery could be cesarean procedure or vaginal birth with additional precaution. Thank you very much for your kind attention, and I give back to MC, Dr. Ricky and Dr. Amal. Thank you.
Thank you very much, Dr. Putrika, Dr. Bulan, Dr. Real, and Prof. Noriaki Emoto for this session. We sincerely appreciate the speakers for their valuable contribution and for sharing the knowledge with us. Okay, for all of the participants and for all of the audience, in front of you there is a QR barcode, and please scan this with your gadget and it will link to our feedback page. Please give your feedback for Jogja Cardiology Update 2024 because your feedback are very meaningful for us. Once again, for all of the participants in front of you, there is a QR barcode, and please scan it with your gadgets, and it will link to our feedback page. Please give your feedback, and your feedback will be very meaningful for us. Following this, we will move to the finalization, which will be the closing ceremony that will be held in Ballroom Tantrum 1 and will be broadcasted into Ballroom Tantrum 3. This will include the announcement of the winners for the flash talk and case presentation, as well as the distribution of the door prize. Participants who have collected 12 stamps from the booths can submit their cards into the fish bowl provided at the entrance of the Ballroom 1. So, well, ladies and gentlemen, I, Ricky, respectfully take my leave. Good afternoon. Wassalamualaikum warahmatullahi wabarakatuh, and see you.
closing ceremony yang dapat dan berhak untuk mendapatkan door Kami ingatkan sekali lagi untuk para hadirin yang sudah mendapatkan 12 cap pada ID card-nya, dapat menaruh ID card di fishbowl yang telah tersedia di ballroom 1 bagian belakang untuk mendapatkan kesempatan untuk memperoleh door prize pada acara closing ceremony JCU 2024. Hanya peserta yang hadir di closing ceremony yang berhak untuk mendapatkan door prize di JCU 2024. Hadirin yang berbahagia, sekali lagi kami ingatkan, bagi Anda yang sudah memperoleh 12 cap pada ID card Anda dapat meletakkan ID card Anda di fishbowl yang ada di belakang ballroom 1 untuk berkesempatan mendapatkan door prize pada acara closing ceremony JCU 2024. Hanya peserta yang hadir pada acara closing ceremony yang berhak mendapatkan door prize ketika dipanggil. Terima kasih. Kepada para peserta juga kami undang untuk mengisi feedback acara JCU 2024 melalui QR Code yang ada di depan. Sekali lagi kami ingatkan untuk para peserta, Anda dapat menuliskan feedback melalui QR Code yang ada di depan atau melalui link yang ada di layar di depan. Terima kasih.